In this surgical video, we demonstrate the microsurgical resection of craniocervical junction meningioma via a far-lateral paracondylar approach. A 29-year-old female presented with complaint of headache and weakness in right shoulder elevation since 3 months. On examination, she was found to have right 11th and 12th cranial nerve palsy with cervical myelopathic features. The preoperative imaging was suggestive of an heterogeneously enhancing extraaxial dural-based lesion spanning across right side of foramen magnum and reaching till C2, approximately 4 into 3.6 into 3 cm, causing significant compression on cervico-medullary junction. The extradural extension was noted inferiorly and laterally, involving the posterior arch and the lateral elements of C1 and C2 on the right side without bone remodeling or erosion. The angiogram was suggestive of narrowing of V3 and V4 segment of right vertebral artery with encasement of right pica. The key surgical steps as shown on the screen were followed during the procedure. The patient was positioned in left lateral position with head secured in a Mayfield clamp. The head was slightly flexed, approximately 30° rotated towards the left side and laterally flexed towards the left so as to optimize the angle of surgical access in the lateral foramen magnum and upper cervical spine. A curvilinear hockey stick incision was marked, extending from just medial to the mastoid tip, curving caudally and medially towards the midline over C2 spinous process. The musculocutaneous flap was elevated in the midline avascular plane, starting from spinous process of C2 till the inion, curving laterally along the superior knuckle line, leaving a cuff of muscle, and then progressing inferiorly till the mastoid tip. The rim of foramen magnum was delineated and C1 arch was identified. The extradural component of the tumor was excised and sent for frozen section. Portion of the tumor that was encasing the V3 segment of right vertebral artery was intentionally left in situ and right suboccipital craniotomy was performed. The posterior arch of C1 was nibbled using Carrison ronger and subperiosteal dissection was carried out along the dorsal surface of C1 arch and continued along the sulcus arteriosus. The vertebral artery was dissected away from the extradural tumor and its muscular branch was identified, secured, and then divided. The residual extradural tumor located near the dorsal margin of foramen magnum was dissected. At this stage, bleeding from the condylar emissary vein was encountered and controlled with bone wax. The right-sided suboccipital craniotomy was extended laterally and inferiorly until the sigmoid sinus was visualized. Partial drilling of posterior one-third of right occipital condyle was performed. Further subperiosteal dissection was done along the sulcus arteriosus till the lateral mass of C1 so as to complete the C1 hemilaminectomy. The remaining extradural tumor surrounding the V3 segment of the vertebral artery was meticulously dissected and taken out in a piecemeal fashion, ensuring the preservation of the arterial wall. The vertebral artery is then mobilized and paracondylar drilling is done. A curvilinear dural incision was made as shown, beginning in the middle of the level of foramen magnum, extending till the level of C2 lamina, superiorly curving parallel to the sigmoid sinus. After dural tacking, the tumor involving the inner layer of dura was sent for biopsy and the CSF was released from cisterna magna. After durotomy, the dentate-ligament, C2 dorsal nerve root, pica were clearly identified. The tumor was planned to be resected via the anatomical corridor between these structures. After initial coagulation of the tumor and minimal debulking, we were able to get a window above and below the C2 dorsal nerve root. At this stage, the pica, the posterior spinal artery, spinal root of accessory, and the dorsal nerve root of C1, along with the dentate ligament, were visualized. The dentate ligament was sharply divided to facilitate the mobilization of spinal cord and enhance access to the ventrolateral tumor. Working through the windows below and above the dorsal nerve root of C2, the lateral dural attachment of the tumor was coagulated and the lesion was internally decompressed. After adequate debulking through the corridors between the C1 and C2 dorsal nerve roots, the inferior aspect of the tumor was accessed and gently teased away from the spinal cord and the surrounding structures. The lateral and ventrolateral dural attachment of the tumor were then coagulated and the lesion was decompressed and removed in a piecemeal fashion, maintaining dissection within safe anatomical planes. The dissection was continued cranially to decompress the superior portion of the tumor located above the dorsal root of C1. The arachnoid is dissected and the spinal root of accessory nerve is identified curving along the dorsomedial aspect of the tumor. The dural attachment of the tumor between the 7th cranial nerve complex and the lower cranial nerves was identified and coagulated and the tumor decompression was done. Following debulking, the V4 segment of right vertebral artery was clearly visualized. The tumor was then dissected away from the artery by working through the surgical corridor on either side of the dorsal nerve root of C1 and the vertebral artery. Further dissection was carried out in the ventrolateral brainstem region, where the tumor was identified between the V4 segment of the vertebral artery and the basilar artery. Using careful microsurgical techniques and internally decompressing the tumor, which were dissected away from both the vessels while preserving the arachnoid planes. The lesion in this critical corridor was removed in a piecemeal fashion, ensuring preservation of the perforators and the adjacent critical nerve structures, particularly in the vicinity of lower cranial nerves and brainstem. At the conclusion of the resection, the remaining tumor was carefully dissected from all the surrounding neurovascular and dural interfaces, and the residual mass was delivered en bloc. At the end of resection, we were able to visualize the 7th cranial nerve complex, the lower cranial nerves, pica arising from the vertebral artery, and the anterior spinal artery arising from left vertebral artery. The anatomical corridors used in the dissection were between 7th cranial nerve complex and vertebral artery, between the vertebral artery and dorsal root of C1, between dorsal root of C1 and C2, and between dorsal root of C2 and dentate ligament. Papaverine soap gel foam were applied to the vertebral artery and kept for 10 minutes. A primary dural closure was achieved with proline 40. The patient did not develop any new onset neurological deficits. The biopsy was suggestive of transitional meningioma, WHO grade 1. Post-operative CT demonstrated the minimum drilling of condyle. We can appreciate the minimal condylar drilling and preserved atlanto-occipital joint, along with a tailored suboccipital craniotomy adapted to the tumor extent. MRI performed at 6 weeks post-operatively demonstrates complete decompression of craniovertebral junction. The vertebral artery, pica, and cervicomedullary junction are free from tumor involvement, as confirmed by comparison with preoperative imaging. Coronal and sagittal sequences reveal resolution of mass effect with no residual compression of the cervicomedullary cord. Persistent T2 hyperintensity within the spinal cord suggests pre-existing myelomalacia or gliosis, secondary to chronic compression, consistent with complete tumor removal and effective neural decompression. In conclusion, the far-lateral paracondylar approach offers a strategically favorable and anatomically sound corridor for microsurgical resections of lesion extending from ventral medulla till the lower segment of C2. This operative video underscores the efficacy of this approach in achieving a broad surgical corridor through limited condylar drilling, C1 hemilaminectomy, and sectioning of the dentate ligament. These maneuvers facilitate multidirectional access to the ventrolateral brainstem and upper cervical cord, enabling gross total resection while preserving the integrity of lower cranial nerves, vertebrobasilar vasculature, and maintaining atlanto-occipital stability. Beyond the paracondylar approach demonstrated, the far-lateral approach includes several tailored variants. The retrocondylar approach avoids condylar drilling and is ideal for posterior and posterolateral lesions, preserving the intrinsic stability. The paracondylar approach widens the lateral corridor while maintaining condylar integrity, which is useful for lateral and ventrolateral pathology. While anterior exposure is required, the transcondylar approach allows limited medial condyle drilling, with extended variants reserved for rare, deeply ventral lesions. The choice of approach is individualized, balancing exposure with neurosurgical safety and craniocervical stability, providing an effective and versatile surgical strategy for foramen magnum and craniovertebral junction lesions. Thank you.